Mike Gibson, Rasha Al-Lamee, and Mike Foley. We're talking about the ORBITA-COSMIC study. Talk to us a little bit, Mike, about the design of the study, the question, and why coronary sinus reduction should work. What was the hypothesis?
So, ORBITA-COSMIC is a randomized, double-blind, placebo-controlled trial of the coronary sinus reducer, and we designed it to address two key questions. Firstly, what is the mechanism of action of the coronary sinus reducer? What we knew before the study was derived from some very old surgical data, some animal models, and some single-arm imaging studies in humans with MRI. But that really hadn't told us the whole story as to how the coronary sinus reducer might work. And the second key question was, what is the true placebo-controlled effect on angina? And that we assessed in ORBITA-COSMIC principally using a smartphone app with daily symptom entry for 2 weeks before randomization and 6 months of double-blind follow-up. So we were
Now,
really
Mike,
trying to use those.
run through some of the prior understanding about how this might work.
So the concept is very old. The concept comes from an era prior to revascularization from the 1940s, and it was pioneered by Claude Beck at the Cleveland Clinic. And the idea was that surgically ligating the coronary sinus could lead to a beneficial redistribution of blood flow in the myocardium. That idea was, in unblinded surgical series, it was very effective in operated patients, but that's obviously unblinded. And that idea really fell away with the advent of bypass surgery and then PCI. It was revisited as a concept because of the emergence of this refractory angina population who, despite all of our existing therapies, still had ongoing symptoms. The coronary sinus reducer specifically has been investigated in imaging studies, and that suggested a redistribution of perfusion as well in unblinded single-arm studies, which was a hypothesis, but certainly not definitive. And that's what we hope to address in ORBITA-COSMIC as well.
Now,
So that
Mike,
was
if you ligate the coronary sinus, where does the blood go? I mean, how's it going to get out of the heart?
So it was ligated to a 3 millimeter lumen. So there is still some flow, and
Okay.
obviously some patients have a contribution from the Thebesian circulation, but it's not a total ligation. The Claude Beck left a 3 millimeter lumen, and that was the basis for the 3 millimeter lumen at the center of the coronary sinus reducer that we now use in practice.
Right. Okay, then take us through how you tested this question.
So patients in ORBITA-COSMIC would firstly and most importantly have a fully quantitative stress perfusion cardiac MRI scan on enrollment to the trial. All patients would be discussed in a dedicated MDT, which included interventionists like Rasha and other interventional cardiologists in our trial group to make sure that there truly were no other interventional options. We would assess patients on a treadmill with symptom questionnaires and establish them on this smartphone symptom application for daily symptom reports. And then they'd enter a 2 week pre-randomization phase to ensure that they had angina and to document their angina severity in that period. They'd then come to the cardiac cath lab where ORBITA-COSMIC, we obviously had the huge benefit of Rash's experience in ORBITA-2 and of course ORBITA, and we used a very similar invasive blinding protocol. So patients were all randomized in the cath lab, having already had a 9 French internal jugular sheath put in. All patients had auditory isolation with headphones playing music. All patients had a deep level of conscious sedation established before being randomized to either coronary sinus reducer or placebo. Placebo patients had no intervention and were kept in the cath lab sedated with maintained auditory isolation for 15 minutes, and reducer patients had a reducer implanted. Everything about both procedures was identical, including medications. And then all patients had a standardized handover to recovery staff with no disclosure of what treatment allocation patients had.
Well, that's very
Patients
important. People following the patient, they didn't know the treatment assignment. So the patient didn't know, and the people following them up didn't know.
Absolutely right. The patients didn't know, and we actually verified that by doing a blinding index on the day of discharge from hospital, and again at follow-up. All caregivers, all research staff doing follow-up assessments didn't know treatment allocation. And for 6 months of blinded follow-up, patients were giving us daily symptom reports before returning at the end of the study to have a repeat stress perfusion cardiac MRI scan, a repeat of their questionnaires and their treadmill test before they were unblinded and returned to routine care.
Well, talk to me about this blinding index. That sounds fascinating. Did you ask them if they thought they got the device or not?
In essence, yes, it's very simple in that we are asking patients, do they know what they had today? Coronary sinus reducer, placebo, or don't know. And I think what we've seen in all of the ORBITA, what is now a family of trials, that there are, these patients, because of the auditory isolation, and particularly, I think, because of the sedation, patients really don't know. They can't offer an answer. I think particularly with ORBITA-COSMIC as well, because it's such a novel procedure, patients didn't have any preconceived ideas really of what they would experience, even if they, those rigorous blinding steps weren't in place. So yeah, that's in essence how it's done, and then we can measure patients, if they can offer an answer, give a degree of certainty between 1 and 5 as to their answer, but that generates this blinding index, which tells us how effective our blinding's been, and that's what we can say in ORBITA-COSMIC, is that our patients were truly blinded.
Amazing. All right. So what did you find?
So we found two key things. The first thing we found is that, contrary to what was seen in single arm studies, we didn't find evidence of an improvement in myocardial perfusion, in myocardial blood flow in segments that were designated ischemic at baseline. What we did find was that despite that, there was a increase or an improvement in angina symptoms with coronary sinus reducer over placebo. And that effect took 10 weeks to emerge and was sustained until 6-month follow-up.
Wow. Okay. Rasha, you have some explaining to do to me. How do you get an improvement in angina with no change in myocardial blood flow?
So, I mean, that is the million-dollar question. And I'll tell you, I came into this trial as a skeptic. This is an investigator-led trial with no support from industry. And actually, I just couldn't understand how this device could possibly work. There was previously a randomized controlled trial that was said to be placebo-controlled. And if I'm honest, I looked at the design of that trial and I thought you could have improved potentially on the blinding. It was admirable that they tried, but they hadn't reported blinding indexes, and we weren't sure how blinded those patients or the medical teams truly were. And so we looked at the studies and we looked at the mechanism of action that was proposed, and we thought that wasn't really proven in single arm studies. So let's do this trial. And I'm going to say I was flabbergasted by the results. The symptom improvement is seen at the point at which we might expect an endothelialization of the device, and that's what started to convince me. And also the symptom improvement was seen across a range of endpoints, from the symptom app to the questionnaires. But we don't know how it works. The overall results from the MRI essentially don't prove don't prove the hypothesized mechanism of action. There was one secondary endpoint that suggests a redistribution of myocardial flow from the subendocardium to the subepicardial segments, but we don't know. And it's interesting because we've recently, myself and Mike also reported a paper that was about the kind of disconnect between mechanism of action of a device and whether you believe that to be intuitive, and then whether you can believe the results of efficacy.
Right.
And we did that questionnaire-based study because we were kind of predicting the fact that, it's hard to understand how a device like this might work. But we did it ourselves, and therefore I've got to kind of stand by our results, and the symptoms improved, and they improved in a genuinely blinded trial. So whether we need to do more studies, whether there's a different way to look for the mechanism of action, by whatever mechanism we need to kind of understand this we need more studies to understand what it all means.
When you say angina improved, was it all exertional angina or did rest angina improve as well?
So interestingly, this was a population of patients in whom we had to really increase the ability to be able to capture all of their angina. So you might remember from the ORBITA app in ORBITA 2, patients were able to report up to 6 episodes of angina, and if they had 6 or more episodes, that was classed in its own class. In ORBITA-COSMIC, we had to go all the way up to 10 or more episodes because these patients were so symptomatic. Some of these patients were having exertional pain, some would have been having rest pain, but with no options for treatment. And for us, that the endpoint that we look at in terms of angina episodes encompasses everything. Any chest pain that they might have had that was triggered by whatever trigger they would have told us at the outset of the trial.
And when you say it improved, Angela, how big was the improvement?
Yeah, so that's interesting. So the odds ratio of angina symptom improvement is of the order of 1.4. So we can certainly see an improvement in terms of angina episodes with the patients who had the reducer. It wasn't as big as maybe we saw with angioplasty in ORBITA-2, but it was
That's what I was
certainly.
going to ask you to compare. How did it compare to angioplasty versus
Yeah.
placebo?
So interestingly, and Mike can certainly come in, this is not a population of patients that you would expect to end up with freedom from angina. That was very rare in this trial. It was more a reduction of episodes of angina as opposed to abolition of angina. That doesn't seem very possible in this very refractory population.
Yeah,
Did you
I
do anything like
agree.
your walk test, their ability to how far they could walk, things like that?
So the treadmill exercise endpoint didn't improve in ORBITA-COSMIC, and that may be for a number of reasons. It may be that the effect size is too small and we're underpowered on that endpoint. It may be because in this patient population, exercise is limited for a number of reasons. This is a relatively comorbid population with multiple medical problems. It may be that treadmill is the wrong modality to assess angina in this particular population. These are patients who actually don't end up in the majority of angina trials. They're certainly not the patients that you would see in trials of PCI in stable angina because they have such advanced disease. It's patients with a sort of relatively, heterogeneous group of different coronary disease endotypes. You've got patients with grafts, CTOs, diffuse disease. And I agree with what Rasha was saying. You wouldn't necessarily expect these patients to become angina free because they have very advanced disease in lots of different territories, and whatever the effect of reducer, it doesn't seem likely that you would necessarily eliminate ischemia or eliminate angina for that population. So I think that's it's relatively unlikely we'd see that.
Interesting. And when you put them on doing any kind of exercise treadmill testing, the time to any ST deviation, did you measure that? I mean, was that no different?
So they had on in terms of the exercise treadmill times, it was that did not change.
I see.
Now again, what I do remember from Mike as he was doing this trial is obviously most of these patients are patients who really had very limited exercise tolerance, and they had limited exercise tolerance for a variety of reasons. They were often quite advanced in their ischemic heart disease, but they were obviously also very comorbid. So no, we didn't see that change in those patients, and we wouldn't be expecting to be able to tell patients that we could improve exercise capacity.
Yeah. And you wonder if somehow for some crazy reason metabolism was altered or something.
Yeah, I mean,
Just
we've always wondered whether people modify what they do or whether it's something like that that changes in these trials, right? And the effect of being in the trial somehow makes them feel better, but that's the reason for it being double-blinded and randomized,
right,
right? And so
right.
all of those extra factors that may have changed them in some way, they didn't seem to they would have come out in the wash really in randomization, we would have hoped. The other thing that was interesting probably to note is these were patients on maximal medical therapy. So again, very different to ORBITA-2. They were on high levels of anti-anginal therapy, and despite that, there was some incremental improvement with the device.
All right. Well, for me, it's a mystery wrapped in a riddle. That's an enigma that's topped in secret sauce. I just don't understand it. I've studied blood flow for 37 years, and this one's got me stumped. So, but you did an honest trial. You asked an honest question. You got an honest answer. And as usual, that always, brings up more questions. So congratulations. So proud of you and your team, Rasha. Amazing, amazing work. We are all very inspired by all that you do. Keep it up. Thanks for joining us. And thanks to all of you for joining us here today.
Thank
Thanks
you.
again, Mike.
Mhm.